Assalamu alaikum and warm welcome, everyone. I am Dr. Asim Ejaz, Consultant Emergency Medicine and Vice President of BIPEPA, the British and Irish Pakistani Emergency Physician Association. So, it is my great pleasure to introduce our speaker, Dr. Immad Qureshi. Dr. Qureshi is a consultant in emergency medicine at Isle of Wight NHS Trust and a founding director and current General Secretary of BIPEPA. BIPEPA is committed to supporting professional development, education, leadership, and collaboration among emergency physicians in the UK and Ireland. And this webinar is part of BIPEPA's growing monthly educational series. And it is our third webinar. A little bit about Dr. Qureshi, who graduated from Army Medical College in Pakistan in 2004. He spent 8 years working in emergency medicine specialist in Saudi Arabia before moving to UK. He completed MSc in critical care and became a fellow of Royal College of Emergency Medicine in 2018. He is a lead examiner for RCAM and previously served as chair of the Emergency Medicine SAS Doctor Forum and member of RCAM Council and a trustee of college. Internationally, he is a IFM CPD lead and has played a key role in developing global emergency medicine education and simulation program. He is also associate fellow of the College of Intensive Care Medicine, a member of Academy of Medical Educator, and a fellow of Faculty of Sports and Exercise Medicine in Ireland. Beyond medicine, he is an international table tennis umpire and officiated at major international sporting events. So please join me in giving a very warm welcome to Dr. Immad Qureshi. So the format is that we have time in the end for the question and answer. If you have any question during the presentation, just raise your hand and I'll take the questions. And you can also write your question or comment in the chat. Over to you, Dr. Immad.
Thank you, Dr. Ejaz, Asim, and welcome everyone to BIPEPA's webinar for August, where I'm going to be talking a little bit about something that is very difficult sometimes to talk about. It is a topic which is very close to my heart, and I feel that we can always strive and try to do this better in the emergency department. So as Dr. Asim said, if you have any questions, please type them in the chat. If you have any questions that you would like to ask in person, I will open the chat, or we will take questions at the end of the presentation. So you can raise your hand at that time and I will allow you to unmute yourself. But to begin with, I'll start sharing my slides and off we go. Asim, if you can just please confirm when you can see my slides.
Okay, yes, I can see your slide.
Perfect. So I've had a very lovely introduction from Dr. Asim, and I don't need to spend any more time on that. But what we're talking about today, and hopefully that is why you've registered for this event, you've seen the poster, you've seen the online events, and you've seen what we're expecting to get through when you registered on Eventbrite as well. I'm going to talk to all of you today about end-of-life care in the emergency department. So it's when the going gets tough and how you deal with those various circumstances. I'll try and keep my talk to somewhere around 20 or 25 minutes so that we have equally amount of time to take questions and have discussions. Now, this presentation is going to primarily be focused at UK practice because it is a presentation for BIPEPA members, but I am going to keep the discussion afterwards, once the presentation is over, open for wherever it is that you are calling in from or joining us from, because I have experience of working in Pakistan, I have experience of working in the Middle East, and I would like to bring all of those practices together so that everybody can hopefully benefit from it, from these discussions. So my objectives for today's talk are to help people who practice in the UK understand the law and the GMC guidance around end-of-life care. I'm going to try and help everybody understand the difference between an advanced directive and a simple do not resuscitate or do not attempt CPR order. I'm going to hopefully help you all, once you go back into your practice, allow your patients who are dying in emergency departments to die with dignity by accepting that this is a normal physiological process that happens at the end of life and does not necessarily mean that we have to throw everything we have at the patient to try and prolong their life and possibly also their suffering. In the UK, but everywhere around the world, we're dealing with an even more aging population. And with this aging population, we get to deal with patients who are coming towards the end of a natural life with no disease process or no acute insult that is causing deterioration. Or sometimes it is an acute insult on top of multiple comorbidities. So we're going to try and talk a little bit about those circumstances as well. And finally, I'm very briefly going to touch on what the role of organ donation or on organ donation and what the role of emergency medicine is within UK practice. Now, like I said, that this is going to be through a series of examples, and it's also going to be going through the various types of end-of-life scenarios or situations or circumstances you might find yourselves in. For ease of a webinar, I'm going to use very clear-cut examples, things where there are no gray areas. But we all know that in actual practice, when we're managing patients, patients don't always fall in very predefined boundaries or boxes. So we have to sometimes think outside the box. We have gray areas to think about and consider. And we can talk about those when we're having our question and answers and further discussions. So when we talk about patients who are approaching the end of their life in the emergency department and those circumstances and those scenarios that I talked about, we need to understand what an advance directive is and the difference between an advance directive and the DNA CPR. And if you can take maybe just this bit away from it, you will have achieved a significant change to your practice if this is not something that you were previously aware of. An advance directive is a legally binding statement or a living will by a patient who has decided that they do not want certain types of interventions. Now, usually the ones that apply to these will be things like not wanting to have CPR, not wanting to be put on a ventilator, not wanting to be admitted to an ICU, sometimes not even wanting to be taken to hospital at all. But if it's recorded with the correct legal documentation, it becomes an advance directive and not just a discussion that has been agreed between the patient and their family or their GP or the nursing home or care home that they're living in. And we'll talk about what the requirements are for that to become a legal document. Sometimes you might see patients who present to you with an advance directive already in place, but somebody else has power of attorney to make decisions on their behalf. And we're going to talk a little bit about the legal aspect of that as well. We're going to talk about patients who are being treated for a certain condition. However, you're trying to determine at what stage are you giving them benefit with the treatment you're giving. And at some cutoff point, it's possible that instead of benefiting them, you're harming them and causing more suffering. And therefore, sometimes we have to make a medical decision that beyond a certain stage, we should not be offering further advanced or intervention or invasive treatments. And we'll talk about that, but the common examples of that are the typical ones where we say we would not offer CPR, or we would not intubate, or we would not offer invasive or non-invasive ventilation, or we would not offer dialysis, for example, or also inotropic support. Now, sometimes when we're talking about these feelings of treatment for patients, we're not, and I deliberately use the phrase feeling of treatment and not feeling of care, because I like to remind myself, and we should all remember, that care never stops, even if a patient is approaching the end of life. So we're still caring for them, but we're just limiting how much treatment they're going to be offered and what that treatment is for. And once you've made a decision about a feeling of treatment, yes, you may record it on a DNA CPR, but it's always better to record it on a treatment escalation plan because that goes beyond just resuscitative treatment. In this, you can list all the treatments that you feel are beneficial and would and should be offered to the patient, and all of those which shouldn't. Now, those are about patients who you are actively treating at the moment. But sometimes you have patients in the emergency department who are already in that stage where they've approached the end of life, or they might be at the final insult that will be um, the it was very close to the time that the patient may pass away, and you've already started an intervention. It could be CPR, it could be intubation, it could be mechanical ventilation, and now you are trying to determine whether it's in the patient's best interest to stop that treatment and to withdraw it. And that can be a different circumstance altogether to when you're still having the discussion around the ceiling of the treatment, to when in an emergency you've already started treatment and now you want to withdraw it or you want to stop it. And then finally, you're going to have patients who are in an advanced disease process, for example. It is an irrecoverable, irreversible, untreatable condition, and therefore all attempts at prolonging life or actively treating that patient are going to end up causing more suffering than they will cause benefit. And in those situations, discussions will be had with the patient and their family around offering palliative treatment, just in case medicine, pain relief, possibly things like palliative chemo. So you are in the emergency department and a patient arrives, and while you're assessing them, they go into cardiac arrest. You expose their shirt to start CPR, and you see this tattooed on their chest. Can I have, with a quick show of hands maybe, how many of you would not do CPR on this patient? Okay, so we've got one hand up. I'm trying to see if there are any more. Yes, we've got a few hands up. Okay. I'll ask you to put your hands down and let's talk a little bit about this situation. So I'm assuming that you've looked at this and you've seen that somebody was serious enough about not wanting resuscitation to have this tattooed on their chest. But if you think about it, does this meet the threshold, the legal threshold to be considered an advance directive? And if it doesn't, then you do not know whether this is a joke, whether this was done to the patient without their consent. You don't know whether when this patient had this done, if they had the capacity to make that kind of decision. You don't know when they made this decision. You don't know if this decision was witnessed by anybody else, and you don't know exactly, doesn't really clarify what they mean by resuscitate. Do they mean do not attempt CPR, or do they mean do not give um, abdominal thrust for choking, for example? And with that, I'd like to explain to you what an advance directive means and what it covers. So an advance directive or a living will has some legal requirements in the UK. The first thing, now see if you can see, maybe if I move to a pointer. The first thing is it has to be dated. It has to state that it's an advance directive. It has to be signed by the person who's giving it. It has to be witnessed. You don't necessarily need two witnesses, but it does need to be witnessed. It needs to clearly state what type of treatment this person does not want if they are in a position, if their health deteriorates to a state where that treatment might save their life. Other things that it legally needs to have is that it has to be but an advance directive has to be, it cannot be made by somebody under 18. And they have to be of sound mind when they make that advance directive, which is one of the reasons why you need to have a witness present. Because we can't always be there, or we won't always be there when somebody drafts this document. But you're expecting the witness to be the person who has made sure that that they are witnessing somebody who's over 18 and in the right frame of mind, leaving us a living will or an advance directive. So if when you remove the shirt of a patient, you see this on their chest, do you think this meets the legal threshold to be an advance directive and we should not do CPR? So show of hands now of how many would not do CPR on somebody if they saw this when they cut open the shirt to start CPR. I'm seeing a few hands go up. That's nice. So I will agree with you that this is a valid advance directive, and this can be used. You do not need to be concerned about whether the patient has, since they had this drafted, whether they have withdrawn consent or not, or whether they have changed their mind. This is a valid living will or advance directive, although it might be a little bit um, in a slightly unusual position or place for you to find, but they're never going anywhere without their skin, are they? So if I leave you with that food for thought for a bit and you can put your hands down, let's talk a little bit about powers of attorney. So we talked about powers of attorney very briefly in the first and the second slides that I had. But essentially, if there's somebody who is incapacitated because of mental health deterioration, because of cognitive decline, and they're unable to make decisions for themselves, they may have drafted a power of attorney for family members or loved ones or people who care for them to make decisions on their behalf. Now, we do sometimes in the emergency department see people who come to the emergency department and some family member or somebody will show up and say, I have power of attorney for this person and I want you to do X, Y, or Z for them. It's very important for you to differentiate and confirm whether they have a power of attorney for property and financial affairs or whether they have a power of attorney for health and welfare, because it's only lasting power of attorney for health and welfare which allows them to make decisions regarding treatment and resuscitation. Now, if you remember, I said a little bit about we'll talk about what happens when somebody has an advance directive and then also somebody turns up with a power of attorney. So somebody has an advance directive that they had made when they were of sound mind and they said that they do not want CPR. And a family member turns up with a lasting power of attorney for health and welfare and they say, I want you to do CPR on this person if you think it will save their life. What the law states in this situation is that the lasting power of attorney does not supersede the advance directive from the patient themselves. So the person, when they were able to make their own decisions, had made an advance directive that said they do not want to be resuscitated in life. And person who's got lasting power of attorney for health and welfare can make other decisions for their health care, for their treatment, but they cannot supersede this advance directive. I hope I've made that a little bit clear. Now, if you remember when I talked about various circumstances, I also did talk about circumstances when there might be situations where you have to withdraw treatment from a patient. So let's talk about one of those circumstances. So if we say that you've got a patient who's come to you, they're 35 years old, they've been involved in a road traffic accident and have had a major head injury. They've had a severe head injury. They have a GCS that is 3 or 4. They come to you, you intubate the patient because they're not maintaining their airway. You start ventilating them. You send them for a CT scan of their head. And this is what the CT shows. You can see that there is, I can bring the laser pointer up again. There is a significant midline shift of probably about 10 or 11 millimeters. You've got a significant bleed in the brain. You discuss this with neurosurgeons and they say that this is not compatible with life. There is no benefit of admitting this patient to ICU. There is no surgical intervention that will help recover this situation. And when you look at the CT and further and go further down, you find out that coning has already happened as well. Now, in a situation like this, you're going to have to make a decision as to whether you do not listen to the advice that's given to you by the specialists. You do not, and you insist that the patient gets admitted to ICU, or that they take the patient to theater, or that they admit the patient under their care. Now, in a healthcare setting like the NHS, which is a public funded, free for all, at point of use healthcare, that is throwing resources at something which we know is not going to be beneficial. And in a situation like this, the correct course of action would be to withdraw treatment, which would be to extubate this patient and admit them to either a regular ward or admit them to a palliation ward if you have one, or an end-of-life ward. The discussions that you need to have around with the family around this can be tricky. The first bit which you need to understand is that, and you need to explain to the family as well, is that this is a medical decision. So we're not asking for their agreement in this. This is a purely medical decision that we are taking based on years and years of experience and lots of evidence around what an injury like this and what findings like this mean for a patient. So this treatment, admitting them, offering them surgery is going to be futile. It's not going to result in any improvement in function, and therefore it's a medical decision that we are going to extubate and we're going to withdraw care. That's the first bit. Now, what does the GMC say about this? Because if it's a medical decision, then do we need to involve the family or do we need to speak to the family? It may make it more difficult for us to manage the patient. They may not understand the decisions that are being made. But the GMC states that unless you believe and you have strong suspicion or belief that the family or the patient are going to be distressed by hearing this information, so they're not that they're going to be distressed by hearing that the treatment is going to be futile, but they're going to be distressed by the information that treatment has to be withdrawn and it's a medical decision, you should tell them. So there are very few circumstances where you would not speak to the family and you would go ahead with your withdrawal of treatment. The GMC says that you should involve the family, and if the patient is not intubated, as this patient is, but some other treatment is being withdrawn, like inotropic support for a patient who is conscious, you should discuss it with them. You should inform them of your decision. So that's one circumstance that we talked about, which is withdrawal of care. Let's move to a slightly different scenario. And this will be one that we will have seen in our emergency departments. Like I said, we're dealing with more elderly patients than we ever have before. So imagine you have a 70-something-year-old male who has presented to your emergency department with a fever, with hypoxia, with signs of chest sepsis. But their background is that they are a COPD patient and they have heart failure and they have renal failure and they're very frail. They are in a care home or a nursing home and they are looked after 24 hours a day. Now, when you think about all the comorbidities that this patient has, you start to build a profile of what to expect. So you've got a septic patient, their BP is a bit low, their oxygen saturations are low. You want to treat their infection. You want to give them the best chance of survival. And in this circumstance, you would take all the steps of the sepsis 6 or your early goal-directed therapy or treatment that you would give your sepsis bundle, and you would give the patient fluids, but cautiously. You would give the patient antibiotics. You would put them on oxygen. You would monitor their intake and output of fluids. You would check their lactate and try and bring it down. Essentially, you would do everything that you need to do to manage sepsis. And if the family members come up to you and say, oh, this happens all the time, this is the third or fourth time that they've had a chest infection this year or in the last 2 years, they always get better. Please, doctor, I'd like you to do everything you can to save my loved one. The discussion that you need to have with them is, you're right, they probably did get better the last few times that they had a chest infection, but it seems like this was a very severe infection. This is in fact a condition called sepsis, if you've heard about it. And then you discuss with them all the comorbidities that this person has. And you say, if somebody like you or me, who is young, who is fit and healthy, were to develop an infection, we would treat it. We could treat it as aggressively as needed, because the body would have the reserves to fight that infection and to tolerate the extreme treatment or the very harsh treatment sometimes which we would give. But your loved one is in a very frail state. We don't think that if we gave them advanced interventions, it would be in their best interest. So what we would probably do in this situation is we will continue to treat their infection with antibiotics, with fluids, with oxygen. We will admit them to a ward and we will see if they are getting better or not. However, what we're not going to do is, if they deteriorate or if they don't improve, we will not be admitting them to the intensive care unit. We will not do CPR on them if their heart stops. We will not put a tube down their throat and put them on a mechanical ventilator if their breathing or if their oxygen levels don't improve. And we will not give them drips or medications that can improve their blood pressure, because that has significant side effects as well. So if things go downhill, that is the ceiling of treatment that we will offer your loved one. We will offer them ward-based care. We will offer them active treatment up to the point where that treatment is not working, or despite the treatment, they continue to deteriorate, in which case we'll have to stop there. Again, the GMC says this is a discussion that you should have with the family and with the patient as well, if they are conscious and able to have that discussion with you. And that was a different circumstance around the end of life. And the final one I talked about was something like a terminal illness, in which the patient knows that at some stage in the future, because of their disease, they are going to die. And the disease itself is not treatable. It's beyond the stage where it can be treated, whether that is with um, chemotherapy or surgery or antibiotics or whatever it may be. So if I gave you an example of a patient who's got advanced abdominal cancer, it's spread everywhere. You can see it in the liver, you can see it in the spleen, you can maybe see it in other organs as well. And this patient has been on a steady decline. They're requiring more and more oxygen at home, they're requiring more and more painkillers. And this patient may turn up in your emergency department in extremis, or with pain that is too severe for them to manage at home. Now, I strongly believe that for a patient like this, the emergency department is not the place to be having that discussion around do not attempt CPR or around end of life care. This is the responsibility of their primary treating team or their general practitioner to have that discussion with them before they end up in an emergency department, to let them know that medically it seems that they are approaching the end of life. And if they do turn up in the emergency department or to the hospital, the treatments that would be offered to them would be symptomatic relief. We'll try to get them onto a hospice bed or a Mountbatten or some other service. Like on the Isle of Wight where I work, we have a ward that is dedicated to end of life, which is our Willow ward. And so we would expect that discussion to already have been had with the patient. So with this, I will move on to the respect form, which is a form of a treatment escalation plan document. This is endorsed by the Research Council of UK, and not every trust uses it, but it is a good place to start because this is more than just a DNAR form. This records a well-documented, summarized plan for both treatment and emergency care for a patient. It can take into account patients' wishes as well. And again, what the GMC say about this is a patient can consent to not having a treatment, to not be treated for something. So they can consent or they can say that they do not or agree to not have CPR or not be admitted to ICU. But if it's a medical decision or it is felt by the treating team that it would be futile to admit them to ICU or to do CPR on them, they cannot insist on having it because it is a medical decision. Finally, I'd like to leave you with some reading tips and so that you can consolidate all this information that I've given you. So the GMC guidance on end-of-life care is the treatment and care towards the end of life, good practice in decision making. The Royal College of Emergency Medicine has an end-of-life care toolkit as well on their website, which you can download. The respect form for healthcare professionals is on the Research Council UK website and on the Respect website. And I'm not trying to blow my own horn, but I had, because I felt very strongly about this, I have published an article in the South Asian Journal of Emergency Medicine, and it's a perspective article on how DNR decisions and what the legislation around it is in Pakistan, in the Middle East, and in the UK. So with that, I thank you all, and I'm happy to take questions. I think we've got about 25 minutes to take questions. Just on this slide, if there's anybody who would like to connect with me, I'll just pop some details on there as well. Just give me a second, sorry.
Any question, just raise your hand. There is a one question on the chat. Would the skin tattoo DNA CPR in your second picture stand in court of law in UK?
Right. So that's my Twitter, Facebook, and LinkedIn handle. You can find me on. And yes, so that is a valid advance directive because it meets all the legal requirements of being an advance directive. It is dated. It is. It clearly states that it is an advance directive, so it has a subject or a title. It is dated. It is signed. It is signed by a witness. It clearly states what the person does not want to have. And based on all of that, in addition to the fact that it should be, you should clearly be able to tell either from the patient's identification or from just looking at them, their general age, that they're over 18. And yes, it would. I'll stop sharing my screen so that I can see everybody and then we'll take it from there.
Any question or comment?
So we've got a couple of hands up. I've got Jabin and we've got Mohammed Butt. So I'll allow them to unmute themselves one by one. Jabin, if you can go first.
First, I think, is Mohammed. Please go ahead.
Right. Okay. Dr. Mohammed, you can unmute yourself as well now. So you have to unmute yourself first and you can ask your question.
Thank you very much, Mohammed.
We can't hear you, maybe.
We can't hear you. I don't know whether it's because your mic is too far away from you.
Yeah, sorry, you can hear me now?
Yes.
Okay, so apologies. I think it was a way to minimize disruption. Mohammed Butt, I'm the medical oncologist. I don't work in ED, but I do run a course on end of life palliative care in Pakistan, an online course. Just a feedback, excellent presentation. Very valid points you have raised. Deliberately asked a question about the skin tattoo. I knew it is useful, but I think just to avoid clarification, I thought paperwork is important, but excellent. Just a feedback. Very good talk.
Thank you very much, Dr. Jabin?
Yeah, thanks, Immad. It's a more of a comment and to share the Canadian perspective. Great and a very important and timely topic because now we are also facing a lot of complex care patients in our departments. And when they come with acute deterioration, it is very, very important for us to know is there any advanced directive? Although I don't deal with the adult population, I only deal with the pediatric population. So one thing I think two things which I want to highlight that even in AHA, which is American Heart Association and Heart and Stroke Guidelines, now they are talking about this continuity of care, which does not stop by the resuscitation measures. And the second point is we do have in our hospital now the pediatric advanced care team, which is some interprofessional teams, which do those difficult conversation with the families, because you can imagine for the pediatric population, there's an extra layer of complexity just because of the age of the pediatric patient, and then their decisions are being made by the parents or guardians or caregivers on their behalf. So they help navigating those conversation, and in our EMR, there's a tab where it is already documented that what is the advanced treatment guidance or how long long we should go, what are the parental wishes, and if the child is like 14-year plus, that what are the child wishes are there for that. It interestingly used to be called as a palliative care team, but now they called it pediatric advanced care team, because with the word palliative, it turns out to be, oh, they are already dying and you are just providing support to die calmly. But now they have changed to pediatric advanced care team, with the concept that this team is helping them to live with a good quality of life rather than help them dying peacefully. So just want to share that perspective with you all.
No, thank you, Javeen. That's actually a perspective which I had deliberately left out from my talk. What do we do when we're dealing with a pediatric population and end of life? I didn't want to cause too much distress amongst the audience, but what you have said is very important around the competence of a child when they're 14 or 15 to understand certain forms of treatment and consent to them, even without the knowledge or without the agreement of the parents. In the UK, we call this Gillick competence, and this is something that if we believe that the child is mature enough, if they have the understanding of what is going to be done to them in terms of treatment, and they want to proceed with that treatment can still be given to the child, even if the parents do not want that treatment to be given. And with children, often it is, compared to adults, it's more common for us to see those circumstances where the parents have a very strong opinion about how to manage a child. The medical team might have a different opinion, and the child may or may not have the competence to consent to treatment as well. And in those cases, sometimes you have to safeguard the child, and you have to then involve the legal team in your hospital as well to ensure that the child is being treated fairly and with the respect and dignity that is due to every human being. So thank you very much for bringing that up to me.
My pleasure. And also, we also make sometime decisions, whether it's a reversible cause or it's a primary progression of their illness, because you can imagine any acute complex patient can present with pneumonia, which is very much reversibly treated. So I completely agree with you. In PEDS, it has many other layers of complexity as well.
Absolutely. And I said this as well. I have used very black and white scenarios in my discussion, in my presentation, but that is for the purposes of time. Like Dr. Butt, I also run a communication skills workshop in which I focus heavily on these various aspects of end of life care. And we have simulated conversations which are more gray than this in that workshop. But there are a few questions that are coming up as well. Asim bhai, do you like to?
First question is, could you briefly identify basic difference between end-of-life care in Middle East and UK?
Okay, that's from Dr. Kamran, I guess. It's a very good question. And when you talk about the difference between end-of-life care in the Middle East and the UK, I guess the treatment and the care should be the same. The principles of management are the same regardless of where we work. We still practice with the ethos of first do no harm. So if our treatments are harming our patients, then we are not upholding our oaths. We are not doing what we were trained to do and what we promised our patients that we would do for them. The difference when it comes to end of life care or decisions in the Middle East and the UK is more around the legislation. So the GMC states that if treatment is going to be futile, then it does not have to be offered. We should discuss it with the family or the patient in every circumstance where we can, except for when we know that it will cause severe distress, it will distress the patient or the family, and that is a situation where we can avoid having that discussion. But it remains a medical decision. What happens in the Middle East? So I practiced primarily in Saudi Arabia, and there was some fatwas, so some Islamic rulings that were given by the Sharia Council, in which what they stated was that three doctors, of whom one should be a consultant and the rest have to be specialists at least, have to decide or agree that treatment is futile, in which circumstance they will inform the patient and the family that treatment is futile and therefore it will not be offered. Another difference between the end of life care in the Middle East and the UK is for because of religious reasons, where the human body and the sanctity of life is held above all else, as um, it is something that is entrusted to us from God, from Allah, when we're talking about treatment or life in the Middle East. Advanced directives are not a part of end of life care in the Middle East. So a person cannot say, I do not want to be resuscitated, or I do not want to. They may have some beliefs around receiving blood products, for example, and there are some, um, but we have similar religious beliefs in the UK as well, with Jehovah's Witnesses, for example, who might absolutely refuse to have blood products or transfusions. Uh, but that, apart from that, there aren't many differences, especially when it comes to the actual care that is given. I know that there's a hand up, but there's two questions here. I think there's one from Ahmed about what constitutes a terminal disease. And Ahmed, thank you for that question. Um, what constitutes a terminal disease would be a disease which is irreversible, which is gone to the stage where it will result in either a complication that will end the patient's life, or its progression itself will result in ending the patient's life. So this is why I say that a terminal disease is not something that should be diagnosed in the emergency department at that point. Um, However, uh, it can sometimes happen that we found the disease at the stage that it became, or when we found the disease, it was already terminal and the patient is at their end of life. So I hope that answers your question. Uh, Vivek, I'd like to take your question before I answer Dr. Butt's question or remark about assisted death. So I'll allow you to unmute yourself, Vivek, and please ask your question.
Yeah, thank you, Imad. Excellent presentation. And apologies, I was a bit late, so maybe you may have covered it, but it's a situation which I've come across three, four times and at different levels that a patient has come in. They are in the kind of a zone of frail area on the frail age side wise. They have got a problem which is common, say pneumonia. If you look at them and you do not know the detailed story, which you do not have in the early stages at times, most of the times, or even if you may have to some extent, a senior person or team member may consider, oh, this is futile, we should not be going further. But I have ended up going further because of reasons. One, till I know fully it's futile, I am not comfortable. And on the top, even if it is futile, I need to know. And when you are moving forward, you are gaining some time for the patient to live, even if they are going to die eventually when you are providing the care. But that gives the time for the relatives to be contacted, or if available, to talk to them when the ongoing care is going on, and to get them prepared and to bring them in as well, and to help them see and say the final goodbye, while with the revival futile treatment going on, but they are kind of alive, and then kind of say a peaceful goodbye. And some patients do come back also who are in not that kind of stage. Having said that, I have noted criticisms or people kind of jumping in who do not understand that philosophy, that these are also an essential aspects which are my experiential thing in the end of life care, because I don't know whether these are given in books or not, but you can highlight that and help me understand that. Is my understanding of the practices over the last 3 decades, and I comfortably follow it despite getting criticisms and questioned later on, but able to justify it if somebody's ready to listen. Any experiences and thoughts about this, please?
Right, Vivek. Thank you very much. And I think you're right. So this the webinar is being recorded and it will be posted on our YouTube channel, on our YouTube page. So you'll be able to go through it again, all of you, and people, you can share it with them as well. But we talked about ceilings of treatment, and we talked about withdrawal of treatment before we came to palliation. And what you are describing is somebody who definitely should have a ceiling of treatment discussion done, but that doesn't mean that you stop treating them. Now, if the circumstance you are describing is somebody who's come in with severe sepsis and pneumonia and they've ended up intubated and on a ventilator, and you have colleagues who are saying that this is futile and it should be they should be extubated, I would, in that circumstance, I would personally allow for family members to come in. I would allow for that closure to be achieved, even if I agree with my colleagues that this is futile, because we have already done an intervention. And as long as we're keeping the patient comfortable, they're sedated, and we're still actively treating the pneumonia, and we haven't yet signed the DNA CPR for this patient, we are okay in continuing that treatment until, and allowing for family members to come in, say their goodbyes, and being present when that treatment is withdrawn. However, if this patient has not yet been intubated and you have colleagues who are saying that treating their sepsis is futile, I would still say I would manage symptomatically as well as actively treat the sepsis, but have a very clear understanding in my mind of what my feeling of treatment is and not go past that feeling. I hope that answers your question as well, Vivek. You are muted, Vivek. I can see you talking, but
Yeah,
you are
sorry.
muted.
Yeah, so but if the similar situation is like in a major trauma, who have come with major severe injuries with cardiac arrest already going on, and you don't have the time at that time to look into things because they are being brought in while CPR is going on. So you will continue with that instead of just giving up straight away just with the primary survey, because a family is there. They have to understand that they have not come to terms with it. And my understanding is, okay, I know that going with CPR is a kind of definitely not going to revert anything. But will you still go ahead with that till the family is bit prepared in relative terms at least, instead of just within 5-10 minutes? Let's continue for 30 minutes, give the family some time, bring them in, show them what we are doing, but tell them that this is going to be futile, so that
Thank
and
you, Vivek.
meanwhile in between something,
Yeah,
wakes up and gives some
no,
goodbye.
no,
That's what I'm trying to say.
I I understand, Vivek. Thank you very much. So now what I've understood is you're talking about a blunt traumatic cardiac arrest, which is a very um, um, which is fortunately not a very common presentation. But if you're talking about a cardiac arrest with blunt trauma, so traumatic cardiac arrest with blunt trauma, then I would probably just ensure that this is not, so I would continue CPR to the extent that I can confirm that this is not a medical cardiac arrest followed by trauma. And once I've reached that conclusion and I'm absolutely positive that this is traumatic cardiac arrest with blunt trauma, I will stop treatment. I will not wait for the family to arrive at that stage, because if they have already seen paramedics doing CPR or anybody else doing CPR, they will have an understanding of how severe the condition is. But um, I would not, like I said, Jabin is saying the same thing, that if you believe that there are reversible causes, so you believe that this is a medical cardiac arrest or a non-traumatic cardiac arrest followed by trauma, then I would continue the resuscitative effort. But if it is purely a traumatic cardiac arrest and it's blunt trauma, I would not continue for a very long time. Thank you, Vivek. I will just see if I can come back to Dr. Butt's comment about changing care in ED. I'm not very certain about what is going to happen in Jersey, but assisted death is not something for the emergency department. I don't know if any of you have seen the last season of The Pit, and they talk over there about something around the lines of the doctrine of dual effect, in which they talk about giving painkillers to somebody who is at palliative stage for their pain, but it also has the effect of increasing their sedation, and they might get to a stage where they lose consciousness and eventually they die. The purpose at that stage is not for us to cause death, but it is to relieve the suffering of the patient. So we're giving it because it is a painkiller. If that has a side effect that it increases the sedation and the patient drifts away into peaceful slumber and never wakes up, that is in itself not assisted dying or assisted death. I did promise you all that I would talk very briefly about organ donation and the role of the emergency department. So in the UK, I hate the acronym, but we have specialist nurses for organ donation. So the acronym for that is SNOD. But we are expected to not have discussions in the emergency department about organ donation with family members. However, wherever possible, we keep those patients on life support who we feel are identifiable or can be organ donors. And we hand that over to the intensive care team, who will then liaise with the SNOD, and they will determine whether the patient should be taken to ICU and follow-up discussions had around organ donation or not. So that was a very brief touch that I was planning to do on that. I don't see any more questions. Dr. Chandika, you said if you're going to get certificates of attendance, we cannot offer those, unfortunately, because like I said, this is a recorded webinar and it will be going on YouTube as well. But please get in touch afterwards and we'll see if we can make something work for you. Asimbai, I hand over to you again.
Thank you. Thank you very much for an excellent presentation. Very important topic, but I think discussed very well, and some good interactive discussion, some important questions. So, well done, everyone, for your participation. And thank you.
Another question is coming, Asimbai.
Yeah. Okay.
Okay, I think we have enough time. We're just because we started about at 5 past. So Amara's asked if we can give a brief overview around the end of life care in Pakistan in these scenarios. The situation in Pakistan is that unfortunately there is currently no legislation that allows doctors or medical personnel to make a decision to not offer resuscitation. So it has to be by the agreement of the family that you are going to withdraw treatment or that you are not going to resuscitate somebody. And that becomes really difficult when there are a lot of family members present. I have had discussions around this. We do this. We also run our workshop on communication skills in Pakistan. And every time we do, I explain that this is an even more important reason that when we're having these discussions in Pakistan, we need to really sit down and offer a lot of time and a lot of explanation to family members. Once they really get a grasp of the situation that this treatment is futile and that despite the futility of it, it's going to cause pain and suffering and harm to their loved one. Sometimes they will understand and they will accept it. Again, I have asked at various forums for not just the government of Pakistan or the legislators, but also prominent health figures such as Shaukat Khanum Hospital and others, that they should be pushing for this. And the reason for that is that Pakistan, as we all know, is a low middle income country. And a family that has a loved one that ends up in ICU on a ventilator for 8 or 9 or 10 days will often have to sell property and sell assets and sell jewelry and other stuff to be able to afford that care, even when the doctors are telling them that this is futile. And then when they can no longer afford it, they agree for treatment to be withdrawn. And then they end up with a loved one who is deceased, which would have been the case 10 days earlier as well. but now they're in massive debt and they may be below the poverty line as well. So it is a need of the hour in Pakistan and surrounding countries for there to be legislation around this so that healthcare professionals can not only protect themselves but also protect loved ones of people who are dying and the people who are dying from undignified, painful, and deaths full of suffering. I'll end with that. Thank you very much, everyone.
Thank you, everyone. Thank you, Dr. Immad.